Good afternoon.
It works.
It works. Okay. Good afternoon. Thank you very much for the introduction. I am palliative care physician with special interest in spirituality. And this is preliminary results from a broader study, and it's part of my PhD. I am also trying to develop a spiritual care model for cancer patients into public hospitals with the hope that we'll be able to then expand. So this is an interesting title, as you say. And I chose it because I think it meant for me, we need to do something. Okay. So I just want to start by acknowledging those who have funded my PhD and the research that I'm doing, Hospivision through the John Templeton Foundation grant, the Female Academic Leader Fellowship at the University of Witwatersrand, and the Bristol Myers Squibb Foundation. This will be the outline of my presentation, and I'm hoping I'll be able to finish within the allocated time. I'm not sure why this is running so quickly. For those who have not been to South Africa, this is the popular Soweto Towers, which are very close to the hospital where I work at, Bara. And I think I want to start by saying we are not different. That's what I'm hearing. We are not different. Patients with cancer in our setting and probably globally have spiritual needs that can be improved when we provide spiritual care. However, the care is not easily accessible. Okay. Two studies that we did in the same setting confirmed that in South Africa, cancer patients' spiritual needs are high, number one. Number two, they are very religious, they are very spiritual. Over 90% of them indicate that they are religious and they're spiritual. Most of them are Christians because in South Africa, apologies. In South Africa, 80% of the population are Christians. Besides being Christians, our patients also have other beliefs. They believe in ancestors. They also go to traditional healers, and sometimes they combine all this. While this is happening in the country, there are research that has been done in Africa that indicates that patients attribute cancer to a metaphysical cause. So I think we must have this at the background as we are going through this. That's the two hospitals and the university at the bottom there. Bara has 3,000 beds, for those who do not know. So as we continue, health professionals, how they view spirituality and spiritual care usually affects how they are going to address their patients, whether they're going to provide the care or whether they are going to leave it out. Apologies. While spirituality and spiritual care concepts are well known and well described globally, we actually do not know what spirituality and spiritual care is in South Africa. So we are using the definitions, EAPC, we're using the consensus definition, but I don't think they actually address what is at the core of spirituality, the way we understand it in South Africa. And the other part that becomes important is that we actually don't even know how health professionals actually view and experience spiritual care and spirituality in Johannesburg. I'll say Johannesburg for now. The aim of our study is to explore the views and experiences of health professionals on spirituality and spiritual care as a component of cancer care. Looking at the methods, we conducted this in two hospitals that are linked to Wits University Medical School, the Charlotte Maxeke Academic and Chris Hani Bara Academic Hospitals. And we did, it was a qualitative focus group discussion with a broad category of health professionals. We did focus group discussions because we thought this would be the ideal. Apologies, I'm not sure why this is jumping up and down. Technology. Okay. And the focus group discussions took between 30 and 45 minutes. We had 9 of them that we conducted, and 2 researchers were then after that did thematic coding, and we agreed on the codes, eventually the final codes with the supervisors and all the researchers. So the results that we got, we had 44 participants, age 44.6, the mean age, and the participant had on average mean 12.6 years of experience since qualifying. Most of them were females. They were nurses, 40% were nurses. The next category that was more was the social workers at 20% and doctors. Then the others followed. Among the participants, only 11 of them, which is 25%, had actually received any training in spiritual care. So when you look at the themes that we got 3 major themes. First theme was the multiple perspectives of spirituality with 2 categories. The provider experiences on spiritual care with 4 categories, and the provider perceived roles of spiritual care. I'll go into the categories. When looking at how they viewed the spirituality, the concept of spirituality became very prominent, and according to the health professionals, they felt that spirituality, according to them, is beliefs, is religion, and the belief is belief in God, belief in a higher being, and also belief in ancestors. They also thought that spirituality has to do with traditional healers. The other part that came very prominently was the fact that they believe that spirituality has to do with connections. And I have a quote there that are supporting what we're able to come out as concepts and connections. The doctor is saying it's issues of faith, belief, of patients, the meaning of faith. They understand it according to their own religion. So it appears as if you cannot separate religion from spirituality in our context. And then the nurse is talking about the belief in God and the belief in ancestors. The social worker is talking about the issue that it's about connection that the patient has with God and with the supernatural. The second category looks at the diversity of both cultural and spiritual beliefs. So according to the professionals, they're saying that patients, some of them are Christians, some of them combine Christianity with traditional, and some of them will have a clear African traditional religion. That one is very clear, where you say, I'm seeing traditional healers, and I also believe in ancestors. They also highlighted, as part of diversity, the role that ancestors play in the lives of patients, especially when they're diagnosed with cancer. So when you look at the code for the assistant manager, she's saying mostly here in South Africa, we see, especially from Black communities, people have dual affiliation, traditional and their specific religion. Whether you are Christian or whether you are Islamic, they will still do the traditional beliefs. The second theme on the provider experiences is the one that became also quite interesting. One of the categories that became very strong is where they are saying that patients look at a cancer through a spiritual lens. So they are making meaning from the diagnosis of the cancer. So they are saying that the cancer can be witchcraft, can be a curse, can be a demonic or evil arrow, can be punishment either from God or from their ancestors, or the illness can be due to a spiritual calling. To be a traditional healer, we call them sangomas in South Africa. And the last quote there makes it very clear that the spiritual counselor is saying sometimes the person, meaning the patient, may believe that they have a spiritual calling. So their ancestors are angry with them and they must ask for forgiveness. Their family will then have to perform a ritual and speak to the ancestors for them to be able to appease the ancestors. The second category under experiences is the request for spiritual care. Request for prayer, very common. And this is the one that became the heading of this topic today. The spiritual counselor was relating where the patient was saying they were going as an interdisciplinary team to see the patient. And the spiritual counselor is saying, when the nurse came in as the leader in the team, introduced the team as the patient was a follow-up. The patient then said, no, today I don't need a nurse. need prayer, and pointed to the spiritual counselor for them to come and do their work. And the nurse had to then back up and allow the spiritual counselor to then do what the lady or the patient had requested for them to do. The other request for prayer for spiritual care is a request for them to call their pastors or spiritual leaders, and also the request for them to be discharged, because some of the rituals that they need to do cannot be done in a hospital. So the patient will then request, can I go home? And I will come back after. Whether they come back or not is another story. But they will then have to be allowed, the nurses will then respect and advocate for them to be discharged so that they can then be able to address whatever spiritual need to be addressed at home. Okay. Then continuing with their experiences, then professionals also recounted areas or times when they felt that the patients were in spiritual distress, and they could clearly identify patients needing forgiveness, patients who are fearing death, and patients would clearly request to say, can you help me? Because I need forgiveness. The second, the story of the spiritual counselor is one that brings to light the importance of being able to be there for your patient. Because the patient, the discussion between, it's a very long discussion, but the spiritual counselor is saying, she comes in, follow up on a patient, and the patient says, the person next door died, I wish it was me who died. And asked why, who wants to die quicker? But the patient wanted to die. And then she says, can you pray for me? Because I can't die. I want to die. So the deliberation between the two then says, the patient then explains to the spiritual counselor, because she can't understand, why do you want to die? She says, I need forgiveness. I have done bad things. I was jealous of people, and starts explaining what it is that she had done to people that makes her believe that this is causing her not to be able to die. That's why she does prayer. Then I was jealous, please pray for me. Then in between, she explains whatever it is that she has done. And after explaining, the spiritual counselor then prays for the patient. And then the following day, the patient died. So the other existential or spiritual distress that was picked up is where patients are saying, I don't know, if I die now, what is going to happen? Where am I going to? The next category is the provider personal spiritual resources for coping, because you ask yourself, how are you able to go through and do what you are doing? And three things became very prominent. Fill your cup. You cannot go and look after a patient if you yourself are empty, if your cup is empty. As explained by the doctor, that for you to be able to give patients the strength, you must have the strength yourself. The social worker explains how they do it. They are doing mindfulness and breathing exercises. And the doctors at the bottom, the radiation oncologist is saying, I'm Hindu, but I can't do this job if I did not have a belief in God. So their belief is the one that is helping them to continue. And the second doctor says, as a doctor, I pray regularly. I pray that whoever comes through my hands, I will be able to do justice for them. So without spiritual care, that is not being provided, even for health professionals. They are saying, I need this. Okay. The third theme on the perceived role of spiritual care, they felt that spiritual care has both benefits, and that spiritual care has undesirable or negative effects on the treatment or cancer care that they are providing. So the perceived benefits, according to the health professionals, was it helps patients to cope, it helps patients to accept their diagnosis, it gives them hope, it improves their quality of life. They also mentioned the issue of forgiveness. It helps patients to receive forgiveness. It also helps reconciliation between the patient and the family. And it also helps the patient in end-of-life transition. And the codes, I think, are very clear. The last code there, the nurse is saying the patient was transitioning. I mean, the patient was dying, but could not die because of fear. And they had to then intervene. The team had to intervene. And as they are intervening, eventually the brother had to forgive the patient. And only then did the patient able to die. And the undesirable effects of spiritual care, according to the health professionals, they say that it delays presentation of patients for care. According to the oncology nurse, she's saying They are taking the patient from healer to healer, from herbalist to herbalist. Apparently, they're also taken to churches, from churches to churches, and eventually they present late to facilities. And then the other challenge that they feel is undesirable, that as doctors, the physician here is saying traditional medicine does not have scientific evidence and is going to interfere with drugs that we are giving our patients. These are some of the codes that are coming through. And the other one is the fact that spiritual care can actually conflict with medical care. We have, I'm not sure if it's happening in other countries, but the code here refers to a specific religion, Jehovah's Witness, who cannot receive blood transfusions. And because they cannot receive blood transfusions, the radiation oncologist was saying, I actually cannot give radiation because the patient is anemic because of their belief system. And then the last one under undesirable defects is the fact that they believe that spiritual counselors can give, spiritual care can then give false hope for our patients. As the psychological counselor is saying, yeah, apologies for the spelling. I think they bring false hope because you are saying God is going to do this for you. And then what happens when it does not happen? The patient has hope that actually does not happen. So based on this, what is coming out of the research is that health providers recognize the importance of spirituality. But in their setting or in Johannesburg, they recognize it as being complex and is also embedded in cultural and spiritual beliefs of patients. And because patients view cancer as a spiritual illness, where, how, and when they will present to a facility is going to depend on how all this are going to work out within the patient. And eventually, if the patient is going to delay in seeking care, going to churches or going to traditional healers, it means that the outcome, because they're presenting late at facilities, the outcome is going to be poor at the end of the day. The delayed presentation at facilities is not new. It's been reported, especially in African countries, where they are saying that patients are going to spiritual leaders or spiritual healers because of the reasons that I have mentioned, and that have also been confirmed by other research to say, because they believe the cause is supernatural, a clinician will not be able to do anything. I need to go and get help first from someone who's spiritual before I come to the hospital. So when as we move on, we need to be able to understand clinicians are saying there is conflict between what we are trained to do and what patients are saying. But at the end of the day, it's a patient who's at the middle. And it's a patient who eventually suffers because we do not want to engage with those who are spiritual leaders, whether they're traditional healers or whether they are pastors or reverends from different churches. One of the quotes that I don't have here from one of the oncologists was saying, I don't have a problem with traditional healers looking after patients in the community, but I don't want them in my MDT meeting, meaning I don't want them in the multidisciplinary team meeting. And we are saying we need to have a care that is comprehensive, that will be able to address all the needs of the patient. But a clinician is saying, not in my space. So providers are highlighting the importance of prayer as a resource for themselves and also for patients, because they are saying that patients are asking for prayer for forgiveness. They're asking for prayer for them to be able to cope. Before they go to procedures, they need prayer. Before they die, they need prayer. So everybody requires prayer, whether you are a health professional or whether you are a patient. So conclusions and recommendations. This study has given us insight into the complexity and the need for contextually appropriate tools that can be able to address the cancer care model in Johannesburg. I will be specific and say in Johannesburg because our patients have pluralistic behaviors. They go to traditional healers, they still come to the hospital, they go to the church. And we are supposed to bring everything together for us to be able to understand why they are behaving in a certain way, for them to be able to navigate the journeys of their patients. So there's a need for us to be able to collaborate, policymakers, clinicians, universities, everyone was to be able to change the care of our patients. And these are strengths and weaknesses and our references. And I thank you.